Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Juliet Morgan and Meghan Jobson. Juliet is a neurologist and a psychiatrist. Meghan is an internal medicine physician. Together, they are authors of the book, Long Illness, A Practical Guide to Surviving, Healing, and Thriving. Juliet, Meghan, welcome to the show.
Thanks for having us.
So I'm going to ask each of you just to briefly share your stories and journeys to where you are today. Then we'll talk about your book. Meghan, why don't you go first?
Yeah, I'm from North Carolina. I went to college in North Carolina. I went to graduate school at the University of Utah, where I got a PhD in neuroscience, came back to Duke and did a postdoc in epigenetics, and then decided that I wanted to work in the clinical side. I'd been a Pilates teacher and done a lot of movement therapies with physical therapists, and really just enjoyed patient stories and working with people more directly on the ground. And so I went to medical school at Chapel Hill, where I also did a research fellowship in glomerulonephritis and vasculitis, worked a lot with people with different vasculitides and glomerulonephropathies. Big hard word for everyone. And then went on to do my internal medicine residency at the University of California, San Francisco, where I also did a fellowship in palliative medicine and also did a fellowship in integrative medicine, which is where Juliet and I overlapped in training. And we came up with the idea for this book.
Excellent. Juliet, please share your story and journey to where you are today.
Yeah. So I went to medical school always wanting to do integrative medicine. I wanted to be a family medicine doc. And then I did neuroanatomy class, and I was just sold on doing something brain related. Went to neurology residency, got really into the hardware of the brain, but realized that a big part of healing was going to be learning about the software, and that psychological change was going to be such an important part of caring for the population that I love. So yeah, I went to med school at Baylor College of Medicine, and then did neurology residency, psychiatry residency, and integrative medicine fellowship at UCSF. And it's where I met Meghan, and kind of deep in the pandemic, actually Meghan was like, let's use this integrative medicine toolkit. Let's work with these long COVID patients. We didn't even really have a name for these patients quite yet. It was just kind of patients who weren't getting better. And then from there, we started to pull together resources, and then we started to put together something that looked a little bit like a workbook. And then here we are now, and we've expanded it to people beyond just long COVID.
All right, so let's talk about your book. It's titled Long Illness, A Practical Guide to Surviving, Healing, and Thriving. So Meghan, tell us, how did this book come together?
Yeah, so like Juliet just kind of went over, we, at the beginning of COVID, we were in different stages of training. And what we noticed is that a few months after COVID started, we had these patients who were coming to us who had COVID and had a lot of different complaints about my toe is blue. Yeah. I feel different. I feel tired. My doctors are telling me nothing's wrong, and I'm just depressed because it's the pandemic. And, the thing we've all heard this story, right?
Yeah.
And then for us, what it really resonated as people who have gone through the trainings that we have gone through, and also myself as someone who has a chronic illness and disability, this is something that we've heard so many times before from patients, and we've heard as ourselves, and we've experienced. I think everyone has experienced being dismissed at some level in medicine. It doesn't matter, some groups definitely experience more, but at some point something's been said to us, and it just happens because it's a speedy game when you go to the doctor, and people are people, and we say the wrong things sometimes. But I think what we really saw was this was a lot like other long illnesses, particularly, the rheumatological diseases, the post-infectious diseases, a lot of people who don't have diagnoses yet, just that confusion and that anger. And it was causing a big rift, really, between the people who are experiencing these symptoms and healthcare providers. One, because the system was so overwhelmed at that point. And even if we wanted to do everything for these people, I mean, we all can remember how chaotic it was.
Yeah.
And so we really wanted to use our tools to help give people information based on what we know from treating people with difficult to treat symptoms, from my palliative care background to the different, psychological aspects from Juliet's background, and then just all of our training together of how we can offer you information that you can put together that can maybe help you on your journey and empower you to know what to say, who to say it to, when to say it to. We have to remember as doctors that when you're sick, coming into the system that you know nothing about is so overwhelming. And we wanted to give people something that they could read and go through and say, that's me, and show it to a doctor so they understand, or a healthcare practitioner, so that they felt empowered and that they felt like they were being seen and heard, because that's super important.
And Julia, one of the things that Meghan said was that patients with these long-term unexplained symptoms are often dismissed by the healthcare system for a variety of reasons. So tell us a story or a case study, or from your experience, about how some of these patients are dismissed. What's that like for them?
Yeah, so even now, I'll see patients who come to my practice with long COVID who just get chronically dismissed and bounced around and don't feel like they have a home base, don't feel like they have an understanding of what their diagnosis is, how it's treated, even the unknowns, the uncertainties. So, I mean, I have plenty of patients too who come to see me who are told it's all in your head. When, one of my mentors, Andy Josephson, the chairman of neurology at UCSF, says, yeah, it is all in your head, right? It's in your brain. It's in your body. So let's take this really seriously. But people who haven't had yet someone who said, okay, let's go a little deeper, or let's think expansively, let's think outside of just biomedical options, let's create, a team. Medicine is the best, I think, when it's played as a team sport. Yeah. And who just feel so abandoned and so lost and are suffering.
And Julia, just to follow up on that, from a clinician standpoint, why do you think that so many clinicians dismiss these patients?
I mean, I've been a really busy physician before, and I think that we encounter this frustration inside of us when we can't fix or change something immediately for someone. There can be feelings of, self-doubt. Am I a good doctor? Do I understand this? Or even just frustration that gets then projected onto the patient when they have something that isn't getting better right away, that we don't have one clear option for treatment around. And I think it's easy for that to happen. And we also hope that practitioners will use our book, because we go kind of through some common symptoms and how these are treated, what referrals the patient can ask for, what referrals a clinician could think about, even like for headaches, kind of an algorithm of, you start with this, these little lifestyle things that you can do. These are low risk natural products that have nice data around them. And then when do you refer to a neurologist? But even then, like, when do you get to a headache specialist? When is Botox a necessity? What about an infusion? What about, a novel antibody treatment? So that people can, begin to have a resource, and practitioners can have a resource that they can use to take care of patients where I think the biomedical approach falls short, both for patients and for clinicians.
So Meghan, take us into the exam room. There are a lot of tools that you mentioned in the book. So how do these, paint a picture about how these tools are in action in the exam room? What are they like? Give us an example.
Yeah. First, if it's okay, Kevin, I wanted to add on to Juliet's answer. So for that last question, so I think, it's a huge task to be a practitioner in a moment with a patient. You're taking in so much, not just the patient there, but the experience of their community, the experience of their ancestors, and all of the issues with society at large. And no one person, no one group of people should be responsible for this. And I think because of the way our healthcare system is structured, often a lot of this is put onto the healthcare practitioner of why couldn't they do this? Why couldn't they understand this? Why couldn't they see this? And so I think we need to remember that and kind of be compassionate towards ourselves. It's like, this is a lot to deal with. And when people come to us, they're coming with all of that as well. I think also we're trained in this society, in this framework, that there's this myth of virility and wellness in our culture. There's this myth of the able-bodied person that honestly serves no one. And it's one of the last big isms that really persists. And even people like myself who have disabilities really struggle with this. You know, I think all healthcare practitioners need to think about their own internalized ableism, because at some point, everyone listening to this is going to get sick. Everyone's going to deal with a complex illness or a disability. And we have a lot of things in our culture that have made us look at people who have disabilities and illness as less than, even though we serve these people. And we need to address that deep-seated feeling in ourselves and the way that our society paints people who have illnesses. And I think when we look into that, and when we look into kind of our own, when we practice, one of the things that I've seen a lot through my training is people I really respect will kind of have these healthism views of, well, if this person wants a liver transplant, they should just stop drinking. Well, if this person really doesn't want to be depressed, they should just get out of bed. These things that are just, we know aren't true based on tons of research. And so I would just say that, a lot of this does take practice and being involved in thinking about these issues. And when we talk about these things and deconstruct them, it actually makes our jobs a lot easier and makes things easier for us. It reduces our stress and helps us understand that, like, there are things we can do to feel better about these interactions that sometimes can be really burdensome on us.
And then also talk about some of the tools that we can use in the exam room to kind of like address these issues.
Yeah. I think, the biggest tool is going to be initially validating a person. And I think we often say, tell me what's going on, and people will pull out their lists and will be like, oh Lord, And so I think we might only have 5 minutes. We might only have 15 minutes. I went into the areas I practice because I can get an hour or 2 hours with a person. But I think the first thing to say is, thank you for coming here. Sometimes our visits are going to be short. I want you to know that I am here for you. And I want to establish a relationship with you over time to help you address the things that are bothering you. And I will work to help advocate for you and be here for you. And I think everyone needs to say that, because just saying that to someone, that's a huge gift that you can give somebody. And whether or not you're going to 100% fulfill whatever that means to them, just letting them know that you're present with them right now in this moment is a great gift. And then, I think just really listening to people's stories. And that's, of course, everyone's going to say, well, I don't have time, that kind of stuff. I think letting people share with you as much as they can. I mean, those kinds of things, letting them walk through the frustrations of different symptoms can be helpful. Because I think most people who come to you who have really bad nausea have probably tried everything and are probably desperate and very vulnerable. And so while, yes, it might be true that they just need to take their Zofran in a different way, you need to let them let it all out first. But I think, there's, in terms of tools, aside from just having a really good dialogue and listening to someone, is, there are a lot of important physical exams that we can do, different tests that we can offer people. And in our book, we go through some examples of those. But I think, like we learn in training, the history and letting people talk will give you so much information. And unfortunately, our system doesn't allow for that as much as it should. It doesn't allow doctors to write good notes anymore to include this. They're like, allergies, Zyrtec, like, can we know more?
So absolutely, we want to create a space. Sometimes that's not available sometimes it is, of course, we want that to be available to patients. So let's talk about a kind of broadly applicable toolkit. So we have things like mindfulness practices. Mindfulness is potent medicine. It's anti-inflammatory. It's helpful for so many myriad conditions. So we go through many different ways of incorporating mindfulness and mindfulness exercises in many of our chapters. There are journaling prompts, as well as an entire chapter on narrative medicine. Narrative medicine can be so important for people with a long illness and help people to really integrate a sense of what this means for them and understand their experience as a whole. We go through natural products, how to pick one, what's safe, how to think about all these different stamps on bottles. How do I pick something? How do I incorporate a natural product into my life, into my care? And for practitioners, so many practitioners I know are texting me saying, how do I pick out a supplement? What is consumer labs? What is GMP certification? Like, how do I begin to pick something that's safe? What's going to be adulterated? What are the standards that are applied to supplements? Then we go through all these different diets, this really big, how to nourish your body, but what's the data and what do I need in different conditions in my area? When I have a patient who has brain fog and cognitive complaints, I'm counseling them on the mind diet because I have really great data to support it, that it slows aging and cognitive outcomes are better. And we have lots and lots of psychological tools. So in our book, we have exercises from cognitive behavioral therapy, dialectical behavioral therapy, acceptance commitment therapy. We have psychodynamic themes. We have so many different ways that you can engage and see what resonates for you so that you can maybe explore more. We do internal family systems work. If you're someone who's experiencing trauma or a trauma response, to see, oh my gosh, I like this. Maybe I'll try and find a practitioner of IFS so that I can move towards that. We think about this almost like a buffet meal. People can take bites of different dishes and then decide that they actually want to explore that further. And we go through how to build a medical team and how to get more of what's going to be increasing your vitality.
So, Julia, just as an example, let's say you mentioned brain fog that's associated with long COVID. So, from your book, what's some specific advice that you could give to clinicians on how to address that?
Yeah, absolutely. For clinicians, I would say this is a really hard complaint to tackle. It's one that comes up in my clinic all the time. And there's so many contributions to brain fog. In our book, we go through a whole rainbow of, our hormonal contributions. Is this actually ADHD, depression, anxiety, inflammation, sleep? Oh gosh, sleep. So there's so many different hydration. The brain is so sensitive to changes in hydration, blood pressure. So really thinking about all the different things that could contribute to brain fog. Really making sure that you've done an adequate evaluation. And then we have a nice excerpt that's published on Psychology Today in case people want to delve a little deeper into the tools that they could recommend. But, we recommend things like increasing socialization. I recommend the mind diet, easy, simple intervention, except dark leafy greens every day.
What is the mind diet for those who aren't familiar?
Yeah. So mind diet is a modified Mediterranean diet. It should be, on the whole, it's kind of just a good, healthy diet. But in a head-to-head trial looking at Mediterranean diet versus mind diet was more protective against progression to dementia. So the big change is there are two things that are different from the Mediterranean diet. One is dark leafy greens every day, which I find really hard. As somebody who's trying to follow the mind diet myself, I find that to be really hard. And then also berries 2 to 3 days a week. But otherwise, things like cooking with olive oil, not with butter, not with saturated fats, reduced sugar, reduced fried foods, red meat only maybe once a week, fish at least 2 days a week, and then veggies and whole grains daily. Not the right diet for everyone, but specifically around brain fog, I try and go for that neuroprotective piece. And that's the diet I'm typically recommending. Then there are other medications. So that we'll use sometimes in patients who have like dysautonomia and brain fog, but like that's a whole other conversation, or MCAS and dysautonomia. So yeah, I would say that rather than getting frustrated by it, get really curious in it, and then, pick a few interventions to try, and always think about sleep. That's probably my number one, is optimizing sleep.
We're talking to Juliet Morgan and Meghan Jobson. They are the authors of the book, Long Illness, A Practical Guide to Surviving, Healing, and Thriving. Now I'm going to ask each of you your take-home messages to the KevinMD audience. So Meghan, why don't you go first?
Yeah, my takeaway message is listen to your patients, let them tell their stories, and, also be compassionate for yourself. It's really hard to practice in this culture of medicine that we have, and remind patients they're not alone and what they're experiencing is real. And there are tools that are out there to help them build a better life.
And Juliet, your take-home messages to the KevinMD audience.
Oh gosh, I just want to echo everything Meghan said, but also that integrative medicine is medicine. And we don't get enough training about how to move beyond biomedicine, how to think about, complementary or alternative medicine, and how to understand whether it's safe or not, and how to begin to recommend that to patients in a way that feels right for you, but that this is something that our patients want, and that there are kind of these simple ways to begin to expand your toolkit if that's something that's interesting to you. And yeah, that it's not easy being a physician, I think, right now in 2023, and that we stand with you, and we take care of, I think, what other people would consider some of the more challenging patients in medicine. And so yeah, we appreciate you listening and hope you'll check out the book.
Well, thank you both for joining me, sharing your time and insight.
Thank you for having us.
Thank you.